His blood pressure numbers were perfect. That is the part that makes this story so hard to understand. Walter is 72 years old, retired civil engineer, the kind of man who tracks things, his numbers, his medication schedule, his morning readings, 3 years on his blood pressure pill, 3 years of excellent control. His last reading was 118/72. His cardiologist had said, and I am quoting, "Whatever you're doing, keep doing it." And then, 6 months later, his wife found him on the bedroom floor. It was 2:17 in the morning. He had stood up to use the bathroom. He had done it 100 times before, but something happened in the 10 steps between the bed and the door that had been happening for months without a name, a tilt, a delay, a brief, unreliable feeling in his legs that he had been telling himself was nothing. This time, it was not nothing. Nothing was broken. But his wife's face, when he looked up at her from the floor, that image stayed with them both. And when they came to see me, Walter said something I have heard more times than I can count. He said, "How does this happen? My blood pressure was perfect." That question is the entire reason this video exists. Because the blood pressure pill that protected Walter's heart for 3 years was simultaneously doing something to his balance system that nobody had measured. Not once. In 3 years of appointments. I am Dr. Amelia Carter. I have spent 20 years in cardiovascular medicine. And I want to tell you something that almost never gets said clearly in a standard appointment. A medication can be working perfectly for the condition it was prescribed for and quietly eroding something else at the same time. That is not a failure of the medication, it is a failure of the monitoring. And the monitoring failure I am going to show you today affects a very specific, very large, very underserved group of people. Adults over 65 on blood pressure medications who have been told their numbers are excellent and have never been assessed for what those excellent numbers are doing every single time they stand up. I am not going to name Walter's medication category yet, not to create suspense, but because there is more than one answer. And if I name one now, some of you will check your bottle, not find it, and assume this does not apply to you. It may still apply to you. You need the full picture first. What I am going to give you is this: the mechanism, the test, the medication hierarchy, and the exact words to use at your next appointment. Not to stop your medication, not to second guess your cardiologist, to add one layer of monitoring that should already be part of your care. Before I show you what was happening inside Walter's body, I want to tell you about the 6 months before the fall, because that is the part that matters most clinically, and it is the part that nobody was watching. Walter's wife, Patricia, had been noticing things, small things, the kind of small things a spouse notices precisely because they are too small to say out loud. Walter touching the wall in the hallway, briefly, a fingertip graze, the kind of touch that says, just checking. Walter pausing at the top of the stairs, not stopping, not hesitating visibly, just a fraction of a second longer than before. Walter reaching for the car door handle when he stood up from the driver's seat, though he had parked on flat ground and had no reason to need it. She had not mentioned any of it to him. She was not sure how to say it without frightening him. And he had not mentioned it to her because he had told himself, as we all tell ourselves, that this was simply getting older. When Patricia described those 6 months to me, she used a phrase I have not forgotten. She said, "He was becoming careful," and I'd never known Walter to be careful. I want to stop here for a moment, because if you are watching this and you recognize something in what Patricia described, in yourself or in someone you love, I want you to know that becoming careful is not a personality change. It is not anxiety. It is not weakness. It is your nervous system doing exactly what it is supposed to do, compensating quietly and efficiently for a change in the underlying system. The careful touch of the wall, the fractional pause at the stairs. These are not signs of aging, they are signs of adaptation. And adaptation in medicine is always worth asking. What is it adapting to? In Walter's case, the answer was something that had never been measured. But before I give you that answer, I need to give you something more important. The reason this is almost never caught before a fall happens. There are 3 structural failures in how blood pressure care is delivered to adults over 65. And together, they create a gap that Walter fell into, and that millions of people are living in right now. The first failure: blood pressure is measured seated, always seated. The appointment begins, the cuff goes on, the number is recorded. Nobody measures what happens 30 seconds later when the patient stands up to leave. The measurement that matters most for fall risk, the standing pressure, the gap between lying and standing, happens outside the clinic, and unless someone asks for it specifically, it is invisible. The second failure, dizziness on standing, is treated as a separate complaint. It goes into the chart as a symptom. It gets attributed to dehydration or inner ear issues or getting up too fast. The connection to the medication on the same prescription is almost never made in the same appointment. The third failure: nobody models what 2 or 3 blood pressure medications do together when the patient stands up at 2 a.m., 8 hours into overnight volume depletion. In a bedroom they are navigating without fully turning on the light. That is the clinical reality, not negligence, not carelessness. A structural gap that produces a specific, preventable, measurable injury in a specific, predictable population. And after this video, you will know how to close that gap for yourself. 3 types of people are watching this right now. The first type is on blood pressure medication and has noticed occasionally a lightheadedness or leg uncertainty when standing from bed or a chair. You have told yourself it was nothing, or you mentioned it once and were told to stand up more slowly. This video will show you that what you experienced has a name, a mechanism, and a test. It is not nothing. The second type is on blood pressure medication, feels completely fine, and has never had that experience. Please stay, because the second mechanism I am going to show you, the slower, quieter one, produces no dizziness at all. It produces something more gradual. A progressive, imperceptible change in gait confidence that builds over months. You may be in that process and have no reason to know it yet. The third type has a parent or a partner whose gait has become more cautious over the past year. They walk a little differently than they used to. They are becoming careful. After this video, you will know exactly what question to ask at their next appointment. There are 2 ways this medication erodes balance. The first one is dramatic enough to produce a fall. The second one is so gradual it is almost impossible to notice until the fall happens. I said the second one is the one I want you to remember. Here is why. The first one, the acute dizziness on standing, is documented, discussed, occasionally managed. The second one is almost never named in a clinical appointment, and it is the one that explains the 6 months of careful touching, the pause at the stairs, the fingertip on the wall. Let me show you exactly what happens inside your vascular system when you stand up. Here is the fundamental problem. When you go from lying or sitting to standing, gravity does what gravity always does. It pulls. Specifically, it pulls approximately 5 to 700 milliliters of blood, close to 1.5 liters, from your chest and upper body down into your lower extremities. In the space of 2 to 3 seconds, your body has a system to compensate for this. It is called the baroreflex. Sensors in the walls of your aorta and your carotid arteries detect the drop in pressure and fire a response. Heart rate increases, blood vessels in the periphery constrict, venous walls contract to push blood back upward. In a healthy young adult, this compensation happens in 10 to 15 seconds. Blood pressure is maintained, the brain stays perfused, the person feels nothing. Think of it like a smart dam. The water level drops, the dam automatically releases more flow from upstream to compensate. Seamless, invisible. After the age of 65, the dam gets slower. The baroreflex sensors become less sensitive. The response time lengthens from 10 to 15 seconds to 20 to 40 seconds. The compensation still happens, but there is a window, those extra 10 to 20 seconds, where the brain is running on less than its full blood supply. Most of the time, in most people, this window is imperceptible. A fraction of a second of slight heaviness in the head. Gone before it becomes anything. Now add a blood pressure medication to that system. The medication has done its job. It has lowered the resting arterial pressure. That is good for the heart. But when you stand up and the blood pools in your legs, the baroreflex is now starting from a lower baseline than the one your body was built to manage. The compensation has to work harder and faster to reach adequate cerebral perfusion. And it is already slower than it was at 45. In some patients, on some mornings, at some doses, it cannot close the gap fast enough. The brain gets briefly underperfused, the room tilts, the legs feel uncertain, the hand reaches for something solid. That is orthostatic hypotension, and it is the mechanism behind a very large proportion of falls in adults over 65 that are attributed to balance problems, inner ear issues, or getting up too fast. Now I want to give you the medication hierarchy. Because not all blood pressure medications carry equal risk, and knowing where yours falls on this list is the first step toward the specific conversation I want you to have. The highest risk category is alpha blockers. These include medications like doxazocin and terazosin. Alpha blockers work by blocking the receptors in the walls of your veins, causing them to relax and widen. The problem is that when you stand up and blood pools in your legs, those widened, relaxed veins do not constrict adequately to push that blood back upward. The dam opens, and the mechanism that should close it is partially disabled. The 2023 American Geriatric Society Beers criteria, the official list of medications considered inappropriate for older adults, explicitly flags alpha blockers as high risk for orthostatic hypotension in seniors. If you are on one of these for blood pressure, that specific conversation warrants attention. The second highest risk category is loop diuretics, furosemide, which you may know as Lasix, and bumetanide. These medications reduce your circulating blood volume. Less fluid in the vascular system means less reserve when gravity pulls blood downward. And in the morning, when you have been lying flat for 8 hours without drinking anything, your circulating volume is already at its daily low point. The orthostatic drop on standing is at its most severe at exactly the moment most falls happen. Third, central alpha-2 agonists. Clonidine is the most common. These medications work by suppressing the central nervous system's sympathetic output, the very system that drives the baroreflex compensation. They lower the baseline pressure and simultaneously reduce the compensatory response. Both problems at once. Then calcium channel blockers. Amlodipine is the most common. Moderate orthostatic risk, primarily from venous pooling with some formulations. And ACE inhibitors and ARBs, which carry lower individual orthostatic risk but become significantly more concerning when combined with a diuretic. And beta blockers, metoprolol, atenolol, carvedilol. Beta blockers blunt the compensatory heart rate increase that is supposed to correct the standing blood pressure drop. The heart cannot accelerate fast enough. The underperfusion window gets longer. Carvedilol, which has alpha-blocking activity alongside the beta-blocking, carries the highest orthostatic risk within this class. I want to take you somewhere that most health content about blood pressure never goes. Not the acute drop, not the moment of dizziness on standing, the months before it. Here's what I want you to imagine. Right now, somewhere in your vascular system, something is happening that has no symptom attached to it. No dizziness, no lightheadedness, no warning. Just a blood pressure that is being maintained day after day, month after month, at a level that is excellent on paper and slightly too low for the precision instrument that depends on it. That precision instrument is your cerebellum and your vestibular system, and it is the machinery that keeps you upright. Your balance is not passive, it is an active, continuous, energy-intensive computation. Your cerebellum, the structure at the base of your brain, is receiving real-time input from 3 sources simultaneously. The vestibular apparatus in your inner ear, which tracks the position and movement of your head, the proprioceptive sensors in your joints and muscles, which report where your limbs are in space, and your visual system, which anchors all of that to the physical environment around you. Your cerebellum synthesizes all of that information 40 to 50 times per second, and makes continuous micro-adjustments to your posture, your gait, your weight distribution. When you walk across a room, across a parking lot, up a staircase, you are not consciously managing any of that. Your cerebellum is managing it for you, silently, automatically, consuming blood and oxygen to do so. What happens when that blood supply is chronically modestly insufficient, not catastrophically insufficient, not stroke level insufficient, just slightly below the optimal range for the precision the system requires? The cerebellum adapts. The brain always adapts. But adaptation has a cost. The computation becomes slightly less precise. The micro adjustments come slightly less quickly. The confidence in an uneven surface is slightly reduced. The gait on uncertain ground becomes slightly more deliberate, slightly, compounding over months into the thing that Patricia was watching from the hallway. There is a second component to this mechanism that I want to explain carefully because the research is emerging rather than definitive, but the physiology is real and worth understanding. Inside your inner ear is a structure called the vestibular apparatus, the semicircular canals, and the otolith organs that detect rotation and linear acceleration of your head. This structure is supplied by a single small artery called the labyrinthine artery. What is distinctive about this artery is that it is an end artery. It has no backup. If the pressure in that artery drops, there is no alternative blood supply to compensate. The vestibular apparatus receives what the labyrinthine artery delivers and nothing more. In patients whose blood pressure is chronically overtreated, pushed to targets designed for younger, more resilient vascular systems, there is reason to believe that the labyrinthine artery's perfusion is occasionally insufficient for the precision that balance requires. Not dramatically insufficient, not enough to cause sudden vertigo, enough to cause a chronic, low-grade reduction in vestibular signal clarity. The world becomes very slightly less stable, and the body responds by becoming very slightly more careful. I want to be precise about what I am and am not claiming here. The acute orthostatic mechanism, the blood pressure drop on standing, the dizziness, the fall risk, is documented in thousands of clinical studies and is not in dispute. The chronic vestibular underperfusion mechanism is real physiology, and there is reason to believe it contributes to progressive gait changes in overtreated seniors. But I am not presenting it as established cause and effect. I am presenting it as a plausible, physiologically coherent explanation for something that clinical practice often cannot explain. Why some patients on blood pressure medication become gradually more cautious in their movement without any single identifiable event. What is unambiguous is this: if a patient's blood pressure target is causing a measurable orthostatic drop, and that drop is going unmeasured, it is reasonable to ask whether a slightly higher target might be safer. Not because higher blood pressure is better, because in seniors, the optimal balance between cardiovascular protection and perfusion adequacy is individual, and it cannot be determined from a seated reading alone. Here is what the clinical distinction between the two mechanisms looks like from the inside. Mechanism 1, the acute drop, produces a specific, identifiable experience, dizziness or lightheadedness, that begins within seconds of standing and resolves within 30 to 60 seconds. It may be severe enough to require steadying. It is consistently tied to the act of standing from lying or sitting. You know it when it happens. Mechanism 2, the chronic erosion, produces no single identifiable event. It produces a pattern, a progressive reduction in confidence on uneven ground, a new habit of touching the wall, a preference for holding the railing you never used to need, a slightly wider gait on uncertain surfaces. None of these feel like symptoms. All of them, taken together over months, are a clinical picture. Patricia described that picture perfectly. Walter had been living inside it for 6 months, and nobody had asked the right question until the night he fell. The 90-second home test. You need one piece of equipment, a home blood pressure monitor, standard upper arm cuff, available at any pharmacy for around $30. If you are being managed for blood pressure and do not own one, this is the most useful $30 you will spend. Here is the protocol. It takes 90 seconds. Step 1. Lie flat on your back for 5 full minutes, not sitting. Flat. This ensures that your blood pressure has fully equilibrated to the lying position and that any postural effects from recent activity have resolved. Take your blood pressure while lying and record the systolic number, the top number. Step 2. Stand up immediately. Do not sit up first. Stand. Within 60 to 90 seconds of standing, not later, not before, take your blood pressure again. Record the systolic number. Step 3. Subtract the standing number from the lying number. This is your orthostatic drop. Here is how to interpret what you find. A drop of less than 10 points, within normal range. Your baroreflex compensation is adequate at your current medication dose. This is reassuring information. A drop of 10 to 20 points, borderline. This warrants documentation and mention at your next appointment, particularly if you have noticed any lightheadedness on standing, however mild. A drop of more than 20 points systolic or more than 10 points diastolic. This meets the clinical definition of orthostatic hypotension. This is a specific, named finding. It is not a description of how you feel. It is a measurement. It goes into your clinical record, and it requires a management response. A drop of more than 30 systolic points. This is a significant finding. Contact your prescriber before your next scheduled appointment. Do not wait. Now here is the most important variation of this test, and it is the one that most directly makes the case to your prescriber. Do the test twice on the same morning, once before you take your blood pressure medications, once 30 to 60 minutes after you take them. Write down both numbers. The difference between your pre-medication drop and your post-medication drop is your medication's specific contribution to your orthostatic risk. That difference, not a description of dizziness, not a report of unsteadiness, a number on a piece of paper, is what changes the conversation with your prescriber. Do this on 3 consecutive mornings. Average the results. Now you have a clinical document, not an anecdote. There is a second self-assessment I want to give you. It is for mechanism 2, for the quiet erosion rather than the acute drop. The tandem stance test. Stand with one foot directly in front of the other, heel to toe, on a flat surface with your arms at your sides and nothing to hold. Time how long you can hold this position. For adults between 60 and 69, 10 seconds or more is the general normal range. Between 70 and 79, 5 to 10 seconds. Below 5 seconds at any age over 60 warrants a formal balance assessment referral. Do this now if you are able before we go any further. Find a clear space near a wall, not holding it. Heel to toe, timer running. Write down your number. That number, alongside your orthostatic test result, is the beginning of a picture that is both more complete and more actionable than anything a seated blood pressure reading tells you. The blood tests and formal assessments that follow a positive home test are also specific. 24-hour ambulatory blood pressure monitoring, the gold standard for understanding your real blood pressure pattern across a full day and night, including the morning window when orthostatic risk is highest. Requested by name. A formal lying to standing protocol at the clinic with measurements at 1 minute, 3 minutes, and 5 minutes of standing. The full protocol captures delayed orthostatic hypotension that a single 60-second measurement can miss. A medication timing review, specifically whether any of your antihypertensives could be moved to evening dosing without compromising their cardiovascular effectiveness. The HYDRA trial, published in the European Heart Journal, found that bedtime antihypertensive dosing improved cardiovascular outcomes while reducing the morning orthostatic drop. For some patients, moving the medication from morning to bedtime is the entire solution, but that decision requires your prescriber, not a self-adjustment. Before I give you the exact words for your appointment, I want to answer the question I know most of you are already asking. The answer is not, stop your medication. Please hear that clearly. The answer is, make sure it is being monitored correctly. The medication protecting your heart deserves to be taken alongside a monitoring plan that also protects your balance. Those two things are not in conflict. They just require the same level of attention. Here are the words. Write these down, or stay on this section and replay it once. These are the specific words for 4 specific conversations. Your exact words at your next appointment. I also want to answer the 3 questions I know are already forming. First question, does this mean my blood pressure is being overtreated? Not necessarily. It means the treatment is doing something to your standing blood pressure that has not been measured. The seated readings may be exactly right for your cardiovascular protection, What changes is not the target. It is adding the orthostatic measurement alongside the seated one, so the picture is complete. Second question, can I just stand up more slowly? Standing slowly is a reasonable short-term strategy. It is not a solution. It addresses the symptom, not the cause. A significant orthostatic drop is a pharmacological finding. Standing slowly is like putting towels under a leaking pipe. It reduces the damage while you fix the pipe. Third question, is any of this reversible? The acute orthostatic symptoms, the dizziness, the lightheadedness, often improve significantly with dose adjustment or timing changes, sometimes within days. The more gradual gait changes from mechanism 2 are more variable. Some patients see meaningful improvement, others partial recovery. What is universally true is that the earlier this is identified and addressed, the more is recoverable. That is the argument for acting now, with the information in this video, rather than waiting for the next appointment to happen on its own schedule. Let me bring this back to Walter and Patricia. Walter's home orthostatic test, done on 3 consecutive mornings before and after his medications, showed the following. Before medication, his systolic dropped 11 points on standing. After medication, it dropped 28 points. His medication's contribution to his orthostatic drop, 17 points. That 17-point number was the answer to his question. That is how this happens when your blood pressure is perfect. His prescriber moved his ACE inhibitor to evening dosing. His loop diuretic dose was slightly reduced with careful monitoring. At his 3-week follow-up, his post-medication morning orthostatic drop had reduced from 28 points to 9. Walter has not fallen since. He has not reached for the wall in the hallway in 4 months. At their last visit, Patricia told me something quietly while Walter was putting his jacket on. She said, "He's not careful anymore. He's just himself again." That is what this kind of change looks like from the outside. Not a dramatic recovery, not a medical triumph, just a person being themselves again, walking the way they always walked, moving through their home without having to think about it. That is what adequate monitoring, done at the right time, can return to someone. Before you close this video, I want to ask you one thing. Do the orthostatic test this week, 3 mornings, before and after your medication. Write down the numbers, then come back and put your post-medication drop in the comments. Just the number, because I have a strong belief about what the distribution of those numbers looks like among the people watching this channel. And when you put yours in, you will give someone else, someone who has been told their numbers are perfect and has been becoming careful for 6 months without knowing why, a reason to do the same test. Your doctor gets 15 minutes, your cardiologist gets 12. This video just gave you what neither of those appointments gave you alone. If this gave you something you did not have before, subscribe, free, first link below. And when you write to me, I write back. Important. Read before acting. If your home orthostatic test shows a drop of more than 30 systolic points, or if standing from bed produces a sensation of near fainting rather than mild lightheadedness, contact your prescriber before your next scheduled appointment. This warrants a same-week conversation, not a waiting period. Do not reduce or stop any blood pressure medication without medical guidance. The cardiovascular protection those medications provide is real. The goal is not to stop the medication. The goal is to monitor it correctly.